Just now we have two excellent presentation, one from Professor Tsuboi, one from Professor Fang, and jointly from our chairman, Professor Chen. So taken together, I think we are entering a new age to try to figure out if we can have uh, a very decent and helpful either biomarker or or accompanied um, diagnosis to try to enhance our ability to treat lung cancer. In particular, MRD is a very nice uh, is a very nice test, which especially in this case where we have tumor informed panel, which means we derived tumor characteristics from the individual patient and use it to tweak if there is any sign of occurrence or recurrence. And because actually we have a lot of choice at this time to treat EGFR resistant the patient with EGFR mutant cancer who are resistant to the first line treatment or the front line treatment. Now we have higher chance to further prolong the PFS, let's say PFS3 or PFS2, but whatever, and taken together we can try to prolong the overall survival for a higher level. This is a very attracting, attracting purpose. Also, we have some concern about the MRD. Here, if we look through the data, which presented by Professor Herbst and now just published by Nature Medicine, and nicely presented by Dr. Tsuboi, the positive product value is somewhere around 91%. The negative predictive value is somewhere around 65%. And actually the most frequent occurrence of MRD positive is 1 year after the treatment. So shall we do any MRD test during adjuvant setting after computer resection while they are taking osimertinib? Because actually we only have 80% of chance to get a positive get a positive test. This is something which I think will take us some time to think about. And the second point is very well illustrated by the case. This case, these female cases, which have a very extended overall survival for more than 10 years, and who receive local therapy, systemic therapy, and osimertinib presently, the mechanism of resistance is MET amplification. And we all know that the novel MET amplification is quite rare for patients, which means if the patient use this kind of tumor-informed board to MRD, MET amplification may not necessarily be a part of its original alteration, genetic alteration. That may bring us a dilemma while the patient have a radiologically progression, but with some other mechanism which not present at the novel tumor-informed panel. which might bring us have to do both examination, MRD and biopsy. So I'm not so sure if my understanding is correct or not. So I really want comment from both Professor Tsuboi and Professor Chen. But do you think this, so MRD from the tumor should be the best way to track down the patient? But if the tumor which is experiencing resistant has developed a new mechanism or new mechanism to be resistant, like small cell, they transform into small cell, or a MET amplification like case. Will the MRD still be the best choice? The core point I want to address is that MRD shows value in this setting and in other setting, but while it will give us additional information besides staging, beside the regular follow-up, and it will give us direct examination of the mechanism for resistance, or the lead time of 5 months is clinically meaningful. I'm still not so sure it will bring us a debut time for MRD in this session. But I really want to want comments from other colleagues and Dr. Tsuboi, if you can hear me, Professor Chen. If I'm not so sure I have made my point clear, but actually because your case is a wonderful case, and the successful so far is so nice, and the patient taught well, and now I'm not so sure if the patient have any evidence of disease. I suppose she is still in her maybe PFF3 period. So actually this but would you give this patient MRD test for not other than the experiment, other than the trial, other than a clinical trial setting, just put into IRD into daily use and try to track down the patient status. So I really have some concern, and I really need your comment at this point. Professor Tsuboi, could you hear me? Professor Chen.
Yes. Let me try to communicate with Dr. Fan. Dr. Fan asked a question about MRD. I have the similar view about MRD. MRD theoretically, I think is great. It's a great idea, but so far I don't think the method, the index is, for example, P53 or other markers, it's mature. I think it's immature right now. For these cases, let me ask the Dr. Fan's questions. If the patient without surgery, if the patient choose your method, radiation for the right side mass for the radiation, and left side radiation, what do you think about it? How do you choose? You know, okay.
Yeah, sure. So actually, for different scenario, we have different concern. Actually, while the patient have no for the right lesion is the, let's say it's the oligo residue, And for the left side, left upper lobe lesion, let's say it's a oligo progression at the times they are presented. They were presented. So actually, I think it's a feasible modality to treat either oligo residual or oligo progression. Combining the patient, their weighting of choice, we'll explain the high and the downsides to choose either radiotherapy or surgery. And actually, I think it's the radiotherapy is still a feasible modality for these patients. There's no decent data or to compare different modality of local treatment. It's based on based on the convenience, the safety, and the patient's choice, the patient's personal choice. So actually, it's a pretty individual based choice. Professor.
So probably your singular is not good, or maybe my singular is not good. I'm not clear. But
no. Actually, nobody will criticize on a success case like this. But actually, I think there's some alternative choice also. Yeah. So no one can predict what.
Yeah, I know. So first of all, do you agree choose some of the local treatment, or just give the systemic, only give the systemic treatment like the TKI or even the immunotherapy, only a systemic treatment?
I think after a very careful investigation to clinical investigation about the progression or residual disease for those have true oligo metastasis or not metastasis, oligo residual or progressive disease, local therapy is quite necessary to overcome the remaining tumor cells.
Which do you prefer, radiation or surgery? Which is the first your choice?
To be honest, it's pretty much depend on the patient preference and the patient's personal status, like pulmonary function, like how big will the portal be for patient who can be treated by SBRT. I think it's a pretty good choice. I'm not a big fan to treat patients with a very large portal.
Yes.
I'm not a big fan of it. So, but for patients who have a small nodule easy to be treated, I think the patient with non-invasive modality is quite decent choice.
Yes. Dr. Fan's comments is very important. Right now, I'm very interested to do the latest stage of a disease, who underwent very good systemic treatment. The tumor shrinked very good. I just do some of the surgery, and I discuss with my radiologist colleagues to discuss which nodules, which disease, which lesions we choose surgery easily because the location is very easy to batch out. If the lesion is a little bit inside, the surgery, if we choose surgery, the trauma probably is bigger than the preferential location. I recommended to do the radiation. My second question for the Dr. Fan, compared to the old days, the radiation's dosage, in my personal opinion, is shrink. It becomes less and less. And the field of the radiation field compared the old days is also become the smaller. I'm right?
Yeah, it's for advanced stage patient, right? We're trying to focus on the viable tumor cell itself. Now we omit the lymph node, prophylactic lymph node irradiation, or elective node irradiation. So we try to focus on the for the viable tumor only.
Thank you so much. So I saw the Dr. Masai present online. Dr. Masai.
Mm-hmm. Actually,
give some of the comments about the case report.
Yeah, actually, I completely agree with Dr. Fan, Professor Fan. So if the patient is has a oligometastasis region is a single or two regions, so SBRT is one of the good choice for in this case. Yeah, actually, in his she's very happy for the more than 10 years. For so only the TKI therapy. So this is my comment.
No, not only a TKI therapy. The patient underwent 2 surgery.
Yes, yes. But the drug therapy
do you think the 2 surgery is helpful for the patient?
Yeah, because so the surgical specimen provided the molecular status. Therefore, very important information for for the patient.
Okay, which do you prefer, the radiation or surgery for this kind of later stage disease?
Yeah, actually, SBRT more prior, but if the patient is not, if the patient easy to detect, remove the tumors, so surgery is one of the candidates for the therapy. But in the SBRT is more strong recommended.
Okay, let me ask a question to Dr. Fan, Dr. Li Yongsheng, Dr. Yue Dongsheng, and Dr. Masai, and Dr. Duan. So the patient underwent so long time of TKI treatment. Right now, the patient used a double TKI from the year of 2021. How we evaluate the TKI's duration of treatment? Lifelong, or some of the so-called drug holiday, stop a while? What's your opinion? Dr. Masai,
Professor Chen, actually, I think we have a little bit run after the schedule, so I will pass this question to Professor Li. Professor Li, would you like to comment on this question?
Okay. Thank you, Professor Chen, for the introduction and the honorable conference chair and Professor Masa and esteemed colleagues. It's a great honor to be here to engage in the international exchange and discussion on the standardized diagnosis and the treatment of lung cancer. For this case, I think it's very successful. I very agree with the Professor Chen's team's decision on this case. I think for the continued treatment, I will determine the CT MRD analysis to assess and predict the clinical outcomes and as well as the treatment decision. If the patient following the progression on the combined targeted therapy, the re-biopsy and genetic testing will be done. I think that will be useful for identifying the resistance mechanisms and adjust treatment accordingly to overcome the resistance. But for how long for the TKI treatment, I think if the MRD is negative, we can have a holiday for the patient. But if the lesion will increase, and I think the MDT is necessary. Thank you. And also from the Professor Masa's lecture and our daily clinical practice, I have learned the following. Firstly, for the patient with resectable stage 1B to 3 CLC, the pre-operative testing for EGFR and ALK can guide the neoadjuvant and the perioperative immunotherapy. And the PD-L1 testing may also be performed to assess the efficacy of immunotherapy. And second, the routine post-operative testing for EGFR, ALK, and PD-L1 can inform subsequent targeted adjuvant therapy and immune adjuvant therapy. Third, the pathological evaluation following neoadjuvant immunotherapy should adhere to industry standard protocols, which include the specimen processing, tumor bed identification, adequate fixation and sampling, and the microscopic identification of residual viable tumor components, and calculating their proportion, lymph node assessment, and providing pathological indicators related to clinical staging and the PCR and PR. And fourthly, the treatment cycle for neoadjuvant immunotherapy combined with platinum containing chemotherapy is typically 3 to 4 cycles and should be adjusted appropriately based on clinical circumstances and the timing of the surgical plan. And in the future, I think the perioperative targeted and the immunotherapy of NSCLC need to address several key issues. How should the duration of adjuvant targeted and immunotherapy be recommended? And should adjuvant targeted or the immunotherapy be combined with chemotherapy? And in addition to MRD, are there any other biomarkers that can predict the efficacy or prognosis of perioperative targeted and immunotherapy for NSCLC? And how can patient evaluation for perioperative targeted and immunotherapy of NSCLC be standardized? Addressing these questions will require I think will require further clinical trials and the real-world data. Thank you.